Okay, let's unpack this. We've got quite a stack of sources on the table today, and they all go deep into differential diagnoses around the knee. But we're not talking about your everyday patellofemoral pain or, a simple ligament sprain.
No, not at all.
Today, we are doing a real deep dive into musculoskeletal oncology. We're looking at the osseous and the soft tissue tumors that demand a fast, accurate read on imaging.
Right.
So think of this less like a lecture and more like a high-stakes morning conference where every little finding on an image could dictate a limb-sparing surgery.
That's a perfect way to put it. For us in orthopedic surgery, especially when you're working up a potential tumor, being able to interpret imaging yourself is, well, it's not negotiable.
You can't just rely on the report.
You can't. You need to be able to look at a radiograph, a CT, an MRI, and immediately start filtering that differential diagnosis based on a few key things.
Like location, patient age.
Exactly. Is it epiphyseal, metaphyseal? How old is the patient? And what does the matrix look like? I mean, is it producing cartilage, bone, or is it just purely letic?
So our mission today is to arm you with those little clinical nuggets that help narrow that field down really quickly.
Yep. We're going to walk through the benign stuff, the more aggressive lesions, and then the truly malignant tumors. And after all that, we'll finish up with something very practical. The power of the ultrasound probe.
All right, so if we're starting with what's most common, we have to begin with the cartilaginous tumors. And that means, of course, starting with the undisputed champion of all bone tumors.
The osteochondroma,
right,
or the exostosis, as we often call it. And this thing is, it's everywhere. The sources say it makes up anywhere from 25 to 50% of all benign bone tumors.
That's a huge number. And 10 to 15% of all bone neoplasms in general.
It is. Clinically, you have to think of this as a disease of youth. You're almost always going to see it present before the growth plates close. So typically before age 20?
And there's a clear male predominance, right? Something like 1.5 to 3.5 to 1.
That's right. And its favorite spot, geographically speaking, is the knee. About 40% of these are found in the distal femur or the proximal tibia. You can see a great example of that in figure 14.1.
From a resident's perspective, this is a beautiful tumor to learn because that imaging criterion is just so clear.
It is, and that is the single most important diagnostic pearl for an osteochondroma. It's that pathognomonic cortical and medullary continuity with the parent bone.
Can you break that down for us? What are we actually looking for?
You absolutely must demonstrate that the cortex of the lesion of the tumor is flowing seamlessly from the cortex of the bone it's growing from, and the marrow cavity has to extend from the bone right into the exostosis.
So it's basically a true outgrowth of the bone itself.
Exactly. If that connection isn't there, you are looking at something else, and you have to assume it's something dangerous, like a surface sarcoma, until you can prove otherwise.
So that continuity is our imaging lifeline. They're often asymptomatic, right? Found by accident after a minor injury.
Very often. But the real clinical challenge, the elephant in the room for any of us who deal with tumors, is that risk of malignant transformation.
And that's where the more advanced imaging comes in, specifically MRI.
Precisely. For a solitary single lesion, the risk of it turning into a secondary chondrosarcoma is incredibly low, maybe less than 1%.
Wow.
But if the patient has multiple hereditary exostoses, or MHE, that risk just skyrockets. It could be anywhere from 3% up to 25%. And in those patients, surveillance becomes everything.
And that surveillance really hinges on one specific measurement, which you need an MRI for. Specifically, the T2 weighted sequence, like we see in figure 14.2.
Yep. You are measuring the thickness of the cartilage cap.
Why the cap?
Because the cap is the active growth zone. Its thickness directly correlates with its malignant potential. So the sources are clear. A cap thickness greater than 2 centimeters in an adult is a major red flag.
So 2 centimeters is the magic number.
Shit, I always tell my residents, measuring that cap is like measuring the fuse on a bomb.
Like
a thin cap, we can watch it. A thick cap, over 2 centimeters, that fuse is getting short, and we start managing it like it's a developing sarcoma.
Wow.
And the MRI is great for other things, too. It helps us see complications like if the mass is pressing on a nerve or vessel. Figure 14.2 actually shows a pseudoaneurysm of the popliteal artery from the mass rubbing on it.
Okay, let's transition now to the second pillar of these cartilaginous tumors, the enchondroma, the quiet giant.
A very good name for it. They are almost always completely asymptomatic. Found, incidentally, one source even cited a 3% prevalence in autopsies.
So people are just walking around with these and have no idea?
A lot of them are. They're benign hyaline cartilage tumors, typically right in the center of the bone and the metaphysis, and they tend to show up a bit later than osteochondromas, usually in your 30s or 40s.
And they also love the knee, distal femur, proximal tibia.
Did you?
So what are the visual clues on a plain radiograph that scream enchondroma?
You're looking for a central geographic lytic lesion, but the real hallmark is the matrix mineralization. You'll see it in about 95% of cases.
And that's the classic arcs and rings pattern.
That's the one. It's basically calcified septa that are surrounding these little lobules of hyaline cartilage. Figure 14.3 is a textbook picture of it.
And if the radiograph isn't totally clear on that mineralization, we'd move to CT.
Absolutely. CT is far superior for picking up subtle, occult mineralization that you might miss on a plain film. It's also great for looking at the endosteal surface, which is, well, it's the key battleground in the differential diagnosis here.
And what about MRI? What's the signature look there?
On MRI, you get this very unique look. The sources describe it as a lobular conglomeration of tiny clustered T2 hyperintense foci.
So very bright on T2.
Extremely bright. It's because of the high water content and all the mucopolysaccharides in that cartilage matrix. It just looks like a very bright, sort of bubbly lesion.
Okay, now for the million-dollar question. The one that decides if a patient just gets watched or if they're heading for a major resection. Differentiating a solitary enchondroma from a low-grade central chondrosarcoma. This is where the WHO grading system really comes into play.
This is where clinical judgment and your imaging synthesis really collide. They're both cartilage tumors. They can both show that arcs and rings pattern. So the key differentiator, the ruler we use, is the degree of endosteal scalloping.
Okay, walk us through those thresholds. How much is too much?
So for a benign enchondroma, the scalloping, which is the erosion of the inner cortex, is usually really minimal. We're talking only about 10% of the cortical thickness, and it's usually just on one part of the lesion. It's a very gentle, localized erosion.
And for sarcoma?
Conversely, if you're worried about a WHO grade 1 or 2 chondrosarcoma, that scalloping will almost always involve more than 2/3 of the cortical thickness, and it'll run along the entire length of the tumor.
This is much more aggressive.
Much more. And if that cortex is completely breached, if there's an extra osseous soft tissue mass, well, that immediately makes it a chondrosarcoma. Game over for the benign diagnosis. An enchondroma should not be leaving the bone.
Wow, it's amazing how a subtle difference, 10% versus 2/3, can mean the difference between observation and a full-blown oncology workup.
It really is. And just like with osteochondromas, if the patient has multiple enchondromas, so all-ear disease or Maffucci's syndrome, the risk of transformation is dramatically higher.
So they need much more aggressive monitoring.
Lifelong vigilance. For Maffucci's, where you have the enchondromas plus soft tissue hemangiomas, that risk can be over 50%.
Before we move on, should we just briefly touch on the periostal chondroma just to round out the cartilage spectrum?
Good idea. They're pretty rare. They're surface tumors that grow just under the periosteum, usually on the metaphysis of the femur or tibia. They cause this sort of saucer-shaped scalloping of the cortex, which you can see in figure 14.4.
And the clinical pearl here.
It's size. Again, size matters in musculoskeletal oncology. If that lesion gets bigger than, say, 3 to 5 centimeters, we start to worry about malignant transformation to a periosteal chondrosarcoma. Size often translates directly to aggressiveness.
All right, let's leave the quiet giants behind and pivot to the lesions that really aggressively announce their presence. And the classic example has to be the osteoid osteoma, the nocturnal ache.
This is one of the most satisfying diagnoses to make in clinic. It's the third most common benign bone tumor, and that clinical triad is just so striking, it's like the patient is reading you the answer key.
So severe pain.
Severe pain that classically gets much worse at night, and this is the real cheat code. It is dramatically, almost completely relieved by a small dose of NSAIDs.
What's the biology behind that specific pain pattern?
It's all about prostaglandins. The central part of the tumor, the nidus, is highly active metabolically. It just pumps out high concentrations of inflammatory mediators, especially prostaglandins.
And NSAIDs are prostaglandin inhibitors.
Exactly. They are powerful COX inhibitors, so they directly shut off the source of the pain. If a patient tells you, I wake up screaming, I take 2 Motrin, and I sleep like a baby, the diagnosis is, for all intents and purposes, made.
Demographically, we're looking at a younger crowd again. Ages 5 to 24, strong male predominance, and they love the knee region.
Very common in the femur or tibia, and imaging is, of course, essential to confirm it.
So what are we looking for on a plain film?
Radiographs will often show that classic picture, a central radiolucency, which is the nidus, and it's surrounded by this thick, reactive cortical sclerosis. You can see it clearly in figure 14.9. About 75% of them are in the cortex, which makes that sclerosis really stand out.
But if we had to pick the single best imaging modality for this one, we're actually leaning away from our usual favorite, MRI, right? CT is better here.
Unquestionably, CT is the modality of choice. It just exquisitely shows you that low attenuation nidus, which might have a little calcification in it, and the dense reactive bone around it. Look at figure 14.10, it's perfect. MRI, on the other hand, can be a massive diagnostic pitfall.
Tell us more about that MRI pitfall. Why is it a problem?
Well, because of all that local inflammation and metabolic activity, the osteoid osteoma causes a huge amount of surrounding bone marrow edema and periostitis.
So it looks bright on the T2 images.
It looks really bright and really angry. And that large field of edema can make the lesion look like a malignant process. It can mimic an early osteosarcoma or even an infection like osteomyelitis.
So if you skip the CT, you might end up doing a massive workup on a totally benign tumor just because the MRI is overreading the situation.
You might. We also look for something on CT called the vascular groove sign, these little linear channels around the tumor that represent the feeding vessels. It's a highly specific finding.
What about nuclear scintigraphy? Does that play a role?
It does, and it gives us one of the most reliable signs in all of musculoskeletal radiology, the double density sign. The detection rate is nearly 100%.
So what is that exactly?
The test shows this intense hotspot of central uptake. That's the hypervascular osteoblastic nidus. That's the first density. Then surrounding that, you see a slightly less intense, but still hot, halo of uptake. That's the reactive bone response.
The hot spot inside a warm halo.
That's a good way to think of it. Before we leave this painful pair, we should quickly distinguish it from its bigger cousin, the osteoblastoma.
Right, they're histologically similar.
They are, but the clinical differences are what matter. Osteoblastomas are bigger, typically larger than 2 centimeters, and most importantly, their pain is usually duller, more persistent, and it often does not respond dramatically to NSAIDs.
So it breaks the classic triad.
Exactly. If it's big and Motrin doesn't touch the pain, you should be thinking osteoblastoma.
Okay, let's shift our focus now from the cortex to the epiphysis. Let's talk about the rare chondroblastoma.
A truly rare one, less than 2% of all primary bone tumors. But when we do see it, it's often around the knee. About half of all cases are in the proximal tibia or the distal femur.
And its location is the biggest clue. It's almost exclusively in the epiphysis or an apophysis. The sources say it might extend a bit into the metaphysis after the growth plate closes. Figure 14.5 illustrates that well.
Yep, mean age is around 20, and again, it favors males. Radiographically, it's usually a small, benign-looking lytic lesion, maybe 1 to 4 centimeters, with thin sclerotic margins.
But just like the osteoid osteoma, it can be an MRI mimic of malignancy.
It really can. Chondroblastoma is often associated with a joint effusion, and it can show really prominent perilesional bone marrow edema and periostitis. So on an MRI, it can look quite aggressive, like in figure 14.5b.
So you have to put it all together. The classic epiphyseal location in a young adult, plus those imaging findings to avoid jumping to a sarcoma diagnosis.
You have to. It's all about context.
All right. Next up is one of the most locally aggressive benign tumors we deal with. Giant cell tumor of bone, GCT.
GCTs absolutely earn their reputation. They make up about 20% of benign bone tumors. They peak in the 3rd decade, so a little older, and they actually have a slight female predominance.
And their love for the knee is, well, it's profound. 50 to 65% of all GCTs happen right there.
They do, and their radiographic hallmarks are just crucial for the diagnosis. They're unmistakable.
So what are they?
Okay, so a GCT is an eccentric olytic lesion. It involves the subchondral bone, so it goes right up to the joint surface. And here's the key. Unlike almost every other benign lesion we've talked about, it has well-defined but non-sclerotic margins.
No sclerotic rim.
No sclerotic rim. You can see it in figure 14.11. That lack of a border tells you the bone hasn't had time to wall it off, which reflects how aggressively it's growing. If you see a subchondral olytic lesion without a sclerotic rim in a 30-year-old, GCT has to be number 1 on your list.
And that local aggressiveness means they can cause cortical destruction, they can expand the bone, and they put the patient at a high risk for a pathologic fracture.
They do. And we also have to watch for secondary changes, especially on CT or MRI.
You're talking about secondary ABC formation.
I am. About 14% of GCTs can develop a secondary aneurysmal bone cyst within them, so you might see those characteristic fluid levels on a T2 weighted MRI, like in figure 14.12.
Which can be a diagnostic trap.
It can, because when people see fluid levels, their brain immediately goes to ABC. You have to remember that GCT is a known primary lesion that can cause a secondary ABC. It adds a layer of complexity.
And scintigraphy gives us another classic sign here.
The donut sign, increased uptake around the periphery with the central area of photopenia, or low uptake. The rim is the reactive bone, and the cold center is the avascular or hemorrhagic core of the lesion.
Another high-yield pattern to remember.
For sure.
Okay, let's wrap up our benign bone tumors with the fibroosseous tumors, the non-ossifying fibroma, or NOF, and the fibrous cortical defect, FCD.
These are basically the pediatric incidental findings. They are incredibly common, present in up to 36% of kids and teenagers. Most of them are self-limiting and just heal up on their own.
They peak in the second decade with a 2-to-1 male predominance.
Right, and radiographically they are textbook. They're cortically based, solytic lesions with a thin sclerotic margin, and they're oriented parallel to the long axis of the bone. Figure 14.6 shows that perfectly.
And the difference between an FCD and an NOF is just size.
Pretty much. The FCDs are smaller and just in the cortex. The NOFs are larger and they bulge into the medullary cavity. They're usually asymptomatic, but we have to recognize them in weight-bearing bones like the distal femur.
Because they can weaken the cortex and lead to a pathologic fracture.
Exactly. If they cause a fracture, they need to be treated. Otherwise, we just watch them and they typically fill in with bone and disappear as the child gets older.
Okay, time to shift gears into the malignancies. And we have to start with the most common primary bone tumor in adults, which usually affects patients in their 7th decade, myeloma.
Myeloma is a systemic disease. It's an abnormal proliferation of plasma cells that leads to this widespread myelolytic bone destruction. You can see a good example in figure 14.13.
And the single biggest imaging trap here is
Relying on plain radiographs. A conventional skeletal survey is just not good enough.
And why is that? What are the limitations?
They are notoriously insensitive. A lytic lesion might not even be visible on a plain film until 30 to 50% of the bone density is already gone.
Wow.
That leads to a devastating false negative rate of 30 to 70%. You simply cannot use a skeletal survey to rule out active myeloma.
So modern staging requires whole-body imaging, which makes whole-body MRI the real workhorse for checking marrow involvement.
That's right. Whole-body MRI is looking for signal changes. It sees marrow involvement as hypointense on T1 and hyperintense on T2 or STR sequences. Basically, it shows where fatty marrow has been replaced by tumor cells.
And we look for 4 distinct patterns of involvement.
We do, and they have clinical correlations. First, you have a normal pattern, which is rare if the disease is active. Second is the micronodular or salt and pepper pattern. It's diffuse but subtle.
Okay.
Third is the focal pattern, where you see discrete lytic lesions. And fourth is the diffuse replacement pattern, where the whole marrow is just gone.
And the focal and diffuse patterns are worse prognostically.
Correct. They correlate with higher disease stages, stage 2 or 3, and a generally worse prognosis. The MRI is indispensable for quantifying that tumor burden and figuring out the risk of an impending fracture.
So where does FDG-PTT fit into this modern algorithm?
It's highly useful. It's great for staging, for finding active lesions, and for tracking how well the treatment is working. It's measuring metabolic activity.
And there's a prognostic link there too.
There is. It's been shown that patients with more than 3 focal lesions on a PT-CT have a significantly worse survival rate.
And there's a critical clinical pearl here about medications.
A huge one. If the patient is on corticosteroids, they have to be stopped at least 5 days before the PT scan.
Why is that?
Because the steroids can suppress the metabolic activity of the plasma cells. So you can get a false negative result, which completely throws off your staging and your treatment plan.
Got it. Okay, let's turn the age clock way back now and talk about osteosarcoma, the most common primary bone tumor in children.
Conventional osteosarcoma makes up about 75% of these cases. It's a high-grade tumor, typically in the metaphysis, and it presents right during those teenage growth spurt years, 2nd to 3rd decade, and it has a strong 2-to-1 male predisposition.
And the pain is usually pretty unrelenting.
Very much so. It often wakes the patient up at night, similar to an osteoid osteoma, but NSIs do absolutely nothing for this kind of pain.
Radiographically, we're looking for a very aggressive mixed picture.
It's a mix of osteolysis, so bone destruction, and malignant osteosclerosis. The tumor is making this disorganized new bone. We describe it as cloud-like or flocculent sclerosis.
And the aggressive periosteal reactions are the classic teaching points.
They are. The sunburst pattern, where you have these calcified spicules radiating outward from the bone, which you can see in figure 14.14. There's also Codman's triangle or the hair-on-end appearance. When you see a sunburst pattern in a teenager's distal femur, the diagnosis is, it's virtually certain.
So the plain films give us the diagnosis, but MRI is really the staging modality for planning the surgery.
Absolutely. MRI is mission critical for preoperative planning. It determines if a limb-sparing resection is even possible.
What's it telling us, specifically?
It's great for delineating the soft tissue component.
Yep.
Has the tumor crossed the growth plate into the epiphysis? And most importantly, what is its relationship to the nearby nerves and blood vessels? We use large field of view T1 sequences to see the marrow extent and S-star sequences to really highlight the soft tissue and the edema.
We have to pause here and discuss a dangerous mimic. Telangiectatic osteosarcoma.
Yes, we do. This subtype is purely hotic. It makes up maybe 12.5% of cases, and it presents with these large, hemorrhagic, fluid-filled spaces, which create prominent fluid levels on MRI.
So it looks exactly like a benign aneurysmal bone cyst.
It's a perfect mimic, and misdiagnosing this high-grade sarcoma as a benign cyst is, well, it's a catastrophe.
So how do we confidently tell the malignant telangiectatic OS from the benign ABC?
The devil is in the details of the enhancement pattern in the matrix. So in a benign ABC, the peripheral rim that enhances is typically smooth and thin, usually less than 3 millimeters thick.
And in the sarcoma?
The telangiectatic osteosarcoma will typically have thick, nodular, enhancing tissue around the periphery and in the septations. But the ultimate tiebreaker is CT.
Looking for bone production.
Exactly. If you can find even subtle occult osteoid mineralization within that lesion, it strongly favors osteosarcoma because an ABC should not be making bone.
Got it. Okay, next up is chondrosarcoma, the third most common primary bone tumor overall. We already said the differential with the enchondroma, but let's talk about the WHO grading now.
Right. So the conventional intramedullary type is the most common. It usually presents in the 30s and 40s. And the WHO grades 1, 2, and 3, they dictate everything about prognosis and treatment.
Grade 1 is low grade.
Very low grade, often very difficult to distinguish from a benign enchondroma. Grade 3, on the other hand, is high grade and behaves like a very aggressive sarcoma.
And the imaging decision point, as we said, is all about cortical destruction.
Precisely. If you're looking at a lesion with that chondroid ring and arc mineralization, like in figure 14.1 steen, you have to ask 2 questions. Is the endosteal scalloping greater than 2/3 of the cortical thickness? And does that scalloping run along the whole length of the lesion?
And if the answer is yes,
if it's yes to either of those, you are leaning very strongly towards chondrosarcoma, probably grade 1 or 2, and that requires aggressive surgery. And if you see a soft tissue mass, that automatically rules out benign disease and suggests a higher grade.
let's touch on the highly aggressive, dedifferentiated chondrosarcoma.
This is a devastating diagnosis. It happens in older patients, 50s to 70s. And it's basically the transformation of a pre-existing low-grade cartilage tumor into a new high-grade sarcoma, often a fibrosarcoma or an osteosarcoma.
So on imaging, it looks like 2 different tumors combined.
It does. You'll see the low-grade cartilaginous part, which is mineralized, and then right next to it, this new high-grade component that is purely limitic, with avid diffuse enhancement and no mineralization at all. That aggressive limitic focus is the red flag.
Our final bone malignancy is osseous lymphoma, the stealth tumor.
Primary bone lymphoma is rare, only about 7% of bone malignancies. But secondary involvement from systemic lymphoma is something we see around the knee. Radiographically, it can be very vague, maybe a moth-eaten or permeative lytic pattern, like in figure 14.17.
So what is the single best feature that sets lymphoma apart from the other aggressive sarcomas we just talked about?
It's unique relationship with the cortex. Lymphoma often demonstrates a relative absence of overt cortical destruction, even when there's a huge tumor present.
That's a huge pearl.
It is. The tumor cells spread through the bone's own vascular channels, the Haversian canals, and they replace the marrow without actually breaking through the cortex. So when you see a massive lesion with marrow replacement on MRI, but the cortical shell is still intact, lymphoma has to be high on your differential. Other sarcomas just bust through the cortex early and aggressively. All right, shifting gears now, moving outside the bone. With soft tissue masses, the job is to quickly filter out the ubiquitous benign fatty masses from the much rarer but deadly soft tissue sarcomas.
And we have to start with the adipocytic tumors. The lipoma is by far the most common benign soft tissue tumor. Clinically, we're expecting a soft, slow-growing, painless mass.
And the imaging is highly reliable. It's diagnostic in up to 90% of cases. The lesion is histologically identical to mature fat, so on CT or MRI, it's going to be isointense to the subcutaneous fat. It's often encapsulated by a thin, dark rim, which you can see in figure 14.18.
And it's worth remembering that intra-articular lipomas are most common in the knee.
They are. Then you have the very distinct, very classic lipoma arborescens.
This one's fun.
It is a fun diagnosis because it's so visually unique, and it's almost exclusively found in the knee, specifically in the suprapatellar pouch. It's a benign proliferation of the synovial membrane that results in these beautiful, villous frond-like projections that are filled with mature fat.
So on MRI.
MRI is diagnostic. You see this feathery, villous fatty mass, isointense to fat, and it's almost always accompanied by a joint effusion. Figure 14.1 shows it well. It literally looks like seaweed floating around in the joint.
Okay, now the stakes immediately get higher when we start considering liposarcoma, the second most common soft tissue sarcoma.
Thankfully, the most common subtype, the well-differentiated one, doesn't have metastatic potential. But the clinical priority here is triage. We have to be able to distinguish a simple benign lipoma from a well-differentiated liposarcoma.
And for that, we rely heavily on the Kransdorff criteria. These are our red flags for a fatty mass.
We do, and you should know them by heart.
So what are the Kransdorff criteria and how do we use them?
Okay, we're looking for 4 specific features. If a fatty mass meets any of these, it's highly suspicious and it warrants a biopsy. Number 1, size greater than 10 centimeters.
Okay, big is bad.
Big is bad.
Yeah.
2, the presence of thick internal septa, specifically thicker than 2 millimeters. 3, the presence of non-adipose globular tissue, so a solid, non-fatty nodule inside of it.
And the fourth?
And 4, if the total non-adipose tissue component makes up more than 25% of the total mass volume.
So in the clinic?
In my clinic, if I see a fatty mass in the thigh that's bigger than my fist, and it has these thick, chunky internal septations that light up with contrast, I am not observing that. We are moving straight to biopsy planning.
Makes sense. Let's move on to nerve sheath tumors. These often show up as masses along the back of the knee or the proximal leg, and we need to differentiate a schwannoma from a neurofibroma.
Right. Schwannomas are usually solitary, sporadic, and they tend to grow eccentrically. They lie peripheral to the nerve they came from, which generally makes them easier to shell out surgically.
And on MRI, they can have some classic signs.
They can. They might show the target sign on T2 images, a dark center of fibrous tissue with a brighter, hyperintense rim of myxoid tissue. They can also show the split fat sign, where a little rim of fat outlines the tumor, separating it from the muscle. Figure 14.22 shows that. And cystic degeneration is very common in schwannomas.
In contrast, the neurofibroma is a much more challenging surgery.
Much more. Neurofibromas arise from multiple cell types, and they are intimately, deeply intertwined with the nerve fascicles themselves.
So you can't separate them.
You cannot separate them surgically without sacrificing the nerve. It makes them much riskier to manage. And for patients who have neurofibromatosis type 1, NF1, the plexiform subtype is the giveaway.
The bag of worms.
The classic bag of worms on MRI. It's this infiltrating heterogeneous mass made of multiple intertwining tumor nodules. A perfect example is in figure 14.23.
Okay, finally, let's cover 2 critical synovial tumors. Synovial chondromatosis and synovial sarcoma.
Synovial chondromatosis is a benign proliferation of cartilage nodules that originate in the synovium. It basically creates a bunch of loose bodies in the joint. About 2/3 of all cases happen in the knee.
And radiographs are often diagnostic here.
They are, because the cartilage nodules tend to calcify, so you end up with these osteochondral loose bodies in 60 to 100% of cases. Figure 14.25 is a great example. The joint just looks like it's full of calcified marbles.
The synovial sarcoma, on the other hand, is aggressive and locally destructive.
And it's a profound misnomer.
Right. It doesn't actually arise from synovial tissue.
Not at all. It comes from primitive mesenchymal cells, usually next to tendons or bursae, and it's the most common soft tissue malignancy of the knee region in children and young adults. It's typically extra-articular, but very close to the joint, as you see in figure 14.29.
And we mentioned calcifications as a potential clue.
They are a crucial clue. Calcifications are present in about 30% of cases. So if you see a soft tissue mass around the knee in a young person and it has calcification in it, synovial sarcoma needs to jump way up on your differential list.
And the MRI findings are pretty complex because it's such an aggressive tumor.
They are. They are highly heterogeneous because they almost always have areas of hemorrhage, necrosis, and fluid. And this gives rise to those famous or infamous descriptive terms.
But triple signal intensity sign.
That's one. It means the tumor has areas of high, intermediate, and low signal on T2 weighted images, which just reflects all the different stuff inside it. And the bowl of fruit appearance is basically describing the same thing.
A mix of different signal intensities.
Exactly. The mass looks like a cluster of varying signal lobules, like a bowl containing fluid, blood, and necrotic tissue all mixed together. That complexity just confirms its high-grade nature.
Okay, here's where it gets really interesting. We've spent all this time meticulously detailing how to identify all these targets with high-end imaging. Now we're going to transition from diagnosis to action. How do we actually hit those targets? Whether it's a knee effusion, a specific bursa, or delivering medication, how do we do it with maximum accuracy? And the answer is the ubiquitous ultrasound probe.
The shift from doing blind injections and aspirations to using real-time ultrasound guidance it's a massive leap forward in procedural accuracy, especially around the knee. The old way was just operator-dependent guesswork. The new standard removes the guessing entirely.
Can you give us the hard data on that accuracy improvement?
The difference is stark. Studies consistently show that intra-articular injections into the tibiofemoral joint when you do them blind can have accuracy rates as low as 70%.
70%? That's not great.
Not at all. With U.S. guidance, that accuracy jumps to 96%. And for the extra-articular targets, the little ones, the improvement is even more dramatic.
Like the Pisanserine bursa.
Exactly. For a deep target like the pes bursa or the proximal tib-fib joint, blind accuracy can be 50%. It's a coin flip. With U.S. guidance, we get 100% confirmation of placement.
That's a huge difference.
It is. I always say injecting blind is like trying to land a plane in a thick fog. Using ultrasound is like flipping on the runway lights. It turns a difficult landing into a routine operation. You wouldn't try to land a multi-million-dollar plane without lights. Why would you waste an expensive drug or risk a complication by injecting blind?
That brings up a critical question. Why does placement accuracy matter so much? Beyond just failing to treat the condition, what are the actual risks of a misplaced injection, especially with steroids?
The risks are significant. They can range from cosmetic to catastrophic. If you put the steroid in the subcutaneous fat by mistake, you can cause local fat atrophy, which leaves a visible dent, or skin depigmentation, a bleached patch.
And the more serious risks?
More critically, an inadvertent intratendinous injection, say, putting steroid directly into the patellar tendon significantly increases the risk of a tendon rupture. We're trying to help the patient, not weaken their major stabilizers. And of course, if you misguide the contrast for an arthrogram, the whole study is non-diagnostic.
So walk us through the general technique for a simple intra-articular knee injection. What probe do we use? What are we looking for?
For a superficial joint like the knee, we'll typically use a high-frequency linear array probe, something in the 8 to 15 megahertz range. It gives you excellent near-field resolution.
And the patient setup?
We'll have the patient lying supine with their knee slightly bent. That maximizes the volume of the joint recess. Then we'll put the probe longitudinally over the suprapatellar region, and we identify the bright hyperchoic cortex of the femur and the dark hypoechoic fluid collection, the effusion, sitting on top of it. That's our target. Figure 15.1 shows this setup.
And confirming you're in the right spot is key.
Absolutely. We track the needle in real time using an in-plane approach so we can see the whole needle, especially the tip, enter that dark fluid. Once we think we're in, we inject a tiny test dose of local anesthetic or saline.
And you're watching the screen as you do that.
You're watching the screen. If you see that fluid spread freely and you see the dark fluid filling the pouch away from the needle tip, we call it the hydrodissection sign, and you feel no resistance, you've confirmed you're intra-articular, then you can deliver the therapeutic agent.
And beyond just the main joint, ultrasound is essential for a whole host of extra-articular procedures around the knee.
The complexity of the anatomy around the joint just necessitates it. Think about injecting the proximal tibiofibular joint, which can be a source of lateral knee pain. or injections along the patellar tendon or the very tricky popliteus tendon sheath. These are almost impossible to get to reliably without visualization.
And deep bursae, too.
Definitely. We use it for the pes anseranus bursa on the medial side. A blind injection there often ends up in the vastus medialis muscle instead of the actual bursa.
What about aspirating fluid or managing cysts, like a Baker cyst or a parameniscal cyst?
Ultrasound is indispensable there. A Baker cyst, that posterior fluid collection, can be really large and tense. We use the ultrasound first to make sure we're avoiding the popliteal artery and vein, and then we can safely aspirate that thick gelatinous fluid.
And parameniscal cysts are much smaller.
Much smaller. They are little ganglia right next to the meniscus. They often need aspiration or injection, and because they're so small and so close to nerves and vessels, ultrasound is really the only safe way to do it.
Let's focus for a second on viscosupplementation. So the use of intra-articular hyaluronic acid.
Right. Viscosupplementation is a valuable tool for our knee osteoarthritis patients who have already failed conservative therapy like NSAIDs and PT. Its efficacy is, well, it's moderate, maybe 20% better than a placebo for pain relief.
Which means placement is critical.
Absolutely critical. It's an expensive treatment. Because the efficacy is modest to begin with, you have to maximize its value by guaranteeing it gets into the joint. If that high molecular weight hyaluronan ends up in the soft tissue by mistake, the benefit is totally lost. You've wasted a resource and frustrated the patient. U.S. guidance ensures every drop lands exactly where it's supposed to.
We have covered a huge amount of ground today. We've gone from, a pediatric incidental finding all the way to a high-grade adult sarcoma, and then finished with the very practical techniques for accurate intervention.
And that synthesis is really the key takeaway from all of this. You have to integrate the patient's demographics with the imaging findings. You need to remember that pathognomonic cortical and medullary continuity of the osteochondroma.
And that critical pearl that an MRI cartilage cap over 2 centimeters needs surgical intervention.
Exactly.
And don't forget that definitive, almost magical clinical triad of the osteodaosteoma, that nocturnal ache that's just erased by NSAIDs.
And the resulting reliance on CT to pinpoint that nidus, which helps you avoid that MRI pitfall where all the edema mimics a malignancy.
Right.
And for the cartilage tumors, you need to use that industrial scalloping rule as your internal pathologist. A benign enchondroma is just a superficial slice, maybe 10% of the cortex.
While a malignant chondrosarcoma, especially a grade 2 or 3, is going to take out more than 2/3. And if it's broken through into the soft tissues,
Then it's game over for a benign diagnosis.
for the soft tissues, we need to know the Kranzdorf criteria by heart: size, septa thickness, and non-adipose content. That's how you spot a potential liposarcoma and decide you need an urgent biopsy.
And you have to visualize those nerve sheath differences. The peripheral surgically resectable schwannoma versus the intertwined neurofibroma, especially that complex bag of worms appearance in patients with NF1.
So at the end of the day, what does this all mean for us?
It means that in musculoskeletal oncology, imaging is not just a picture. It is a detailed surgical map. We use plain films for mineralization, CT for subtle cortical and matrix details, and MRI to define the marrow and soft tissue extent.
And integrating all of them.
Integrating them, knowing the difference between the GCT's donut sign and the neurofibroma's bag of worms, that's what empowers you as a physician to drastically limit the differential, speed up the workup, and ultimately save time and potentially save limbs.
Okay, before we close out, I want to leave you with one final thought to mull over.
Let's circle back to the synovial sarcoma. We noted that despite being a very aggressive, high-grade malignancy, the presence of matrix calcification, which we see in about 30% of cases, is paradoxically associated with a better overall prognosis.
Which is counterintuitive.
It is. So we have to ask you, the listener, what is it about matrix mineralization, the presence of calcium in such a high-grade tumor that suggests a more favorable outcome? Could it indicate a different underlying cellular or genetic differentiation? And how might researchers use that subtle clue to maybe target less aggressive cell lines in future therapeutic strategies? That's a fascinating thought that builds directly on all the details we've explored today.